So here are the objectives. I'm going to be a little bit of a Debbie Downer in this talk because I'm going to show you that a lot of the stuff we do has a lot of limitations, and I'm not 100% sure that heterotaxy-associated ciliary dysfunction exists. I think it exists clinically. I just don't know that we have the right test to look for it thus far. So I've already talked about PCD. One of the things I want you to know is PCD is actually a lot more common than we used to think. We used to think it was 1 in 30,000. When we look at just 29 genes and look at the prevalence of those variants in those 29 genes, and again, there's over 60, that puts the prevalence based on a lot of different genetic databases about 1 in 7,600. So it's about as third as common as cystic fibrosis. So if you think of your cystic fibrosis population as your hospital, and there are 300-400 kids, you've probably got about 150 PCD running around. And again, we know that laterality defects, situs ambiguous, heterotaxy, whatever you want to call it, actually occurs in up to a quarter of those kids in the right populations. And really, the key to picking out a kid with PCD is to look first at the 4 key clinical symptoms. Neonatal respiratory distress with oxygen or CPAP need in a term infant. In many kids with heterotaxy with heart defects, that's a given. Okay. Early onset, year-round wet cough. It never, ever, ever goes away, even on the best day in the middle of summer. Early onset, year-round nasal congestion. Never, ever, ever goes away. It's present before daycare. It's present at age 12. It's always there. And then any organ laterality defect, which is where heterotaxy falls into this. If you have 2 or more of those symptoms, you're 80% likely to have PCD. But if you have all 4 of those, you're 99% specific, and so you probably have PCD right there. And it's those kids with 2 or more symptoms that, like Yadira talked about, that need to be sent to pulmonary medicine. The problem is many kids with heterotaxy, you're getting asked about them in the neonatal period, and they haven't had time to establish this phenotype yet. And once you then know this is a kid we want to work up for PCD, the problem is our tests don't detect it all. About 20% of the kids, despite all your testing, will have inconclusive diagnostic tests. The 2 gold standard tests per the new ERS ATS guideline are a genetic mutation, at least a biallelic variant, a known PCD gene that is autosomal recessive. There's a few non-recessives, or electron microscopy defects. And then a screening test is nasal nitric oxide, which can be done in kids over 5 years of age, and we now can do it down to 2 years of age, but about 10% of those will be completely normal in PCD. And then you've heard a lot of talk about high-speed video microscopy, or measuring the beat pattern looking for ciliary dysfunction, and then lastly immunofluorescence. I'm not going to talk much about that. But I need people to recognize the limitations of high-speed video microscopy. In some European centers, and it's mainly 3 centers in the UK, it was their previous gold standard for PCD diagnosis. And you basically can scrape cells out of the nose right there in clinic, and you can look under a special high-speed video microscope and record it and look at playback later. And if you have normal beat, we all saw what normal looks like. If you have an outer dining arm defect, often you'll have totally immotile cilia, some flickering, but not a lot. The problem becomes there's variants where inner dining arm defects with microtubule disorganization and some others will have a slightly decreased amplitude, or like Dr. Lowe said, a wavy appearance, and then central apparatus radial spokes will look normal from the side, but from the top you'll see whirling, so you have to look at it in different phases of view. And the big problem with this is there's absolutely no standardization to how you interpret this, okay? There's a lot of subjectivity in how it's done, how it's prepared, how it's read, and even normal controls vary between many different labs. And so if you haven't done 500 to 1,000 of these, you're not doing them correctly, and you are misdiagnosing left and right. It is a very, very, very hard test to do. The other problem is secondary ciliary dyskinesia can be caused by a virus, smoking, meds in the nose, recent instrumentation, recent surgery, recent anesthetics that were inhaled. We just don't know what all of those things do. And so the European recommendation is actually to do this after air-liquid interface and regrowth of the cells for 6 weeks, which is pretty difficult to do in a clinical circumstance. Or you have to bring the patient back 3 times and do 3 different readings, 3 different samples, 3 different readings, and hope they're the same. Well, that's easy to do when your country's the size of Belgium. It's much harder to do when you have patients coming from hours and hours away. So nasal nitric oxide is another screening test that we use, and for some reason the values are incredibly low in PCD, often 1/10 of what it is in a normal person. Values less than 77 nanoliters per minute in an older kid that can blow into a resistor are incredibly sensitive and specific for PCD. Once you get below age 2, like Dr. Lowe told us, the normal levels of NO increase with age, probably due to sinus growth. It's very, very important. You have to do this with proper validated machines. Chemiluminescence analyzers, which cost over $100,000, and an appropriate protocol must be used, or else the values just aren't reliable. Okay, and you have to repeat this because, as I'll show you, it can be low from many, many different causes, and an isolated nasal NO on one occasion doesn't mean much. Okay, it's got to be repeated, and of course these special devices are not FDA approved. But you can see it's a pretty easy test to do. These are my 2 children when they were young, acting as my research subjects. I signed consents to put them in the articles. It's fine. But they're blowing into resistors. The little sponge is in the nose, no deeper than a finger. They all laugh when I tell them that. It's gently sucking out nitric oxide, and it's measuring it in real time when you get to a plateau, a steady state, which you can see on the graph that comes from the computer software. And we've actually looked at this in many, many different types of heterotaxy, which was called situs ambiguous at the time because that's what reviewers made us use. But we looked at people with what no one in this room would bat an eyelash at, calling this heterotaxy. We looked at kids with simple cardiovascular defects and other laterality defects. We looked at kids without heart defects, but just organs that were malformed and flipped, and some that just had like an interrupted IVC or an isolated right aortic arch. And when they had PCD, the nasal nitric oxide was incredibly low. You can see the value here is well below 100 in all these patients. But it can be low with other diseases. It can be low in about a third of cystic fibrosis, so you have to have ruled that out. It can be incredibly low with a viral infection, and it will stay low for weeks with viral infection. And the problem is you're doing this in 2-year-olds who are in daycare and always viral. So I've had kids fool me for years, and I've said, come back when you're 4 years of age in the middle of summer and we'll try it then, and they've gotten normal. If you had any recent nasal instrumentation, they can't just come from ENT clinic where they got scoped, it will be low. If they've had bleeding, blood is a sponge for NO. It will soak up NO and give you low values. If you use non-standardized protocols or devices, you'll have low values. So it is fraught with things that will make it insensitive and unspecific. Electron microscopy was the gold standard for PCD for many years. You scrape some cells out of the back of the nose, or you scrape some cells from the lower airway, and you look under the electron microscope. On the left, you can see that that's a normal ciliary EM with the nice hooked comma-like outer dining arms and the 9+2 configuration. Then in figure B, you see you're missing the hook, the comma of the outer dining arms. In the next one, you're missing the outer and inner dining arms. And in the third one, you have microtubule disorganization with absent of the inner dining arms. And again, incredibly difficult to do. We only have one single lab in all of Canada that does this. We have 2 PCD Foundation accredited labs in the US, and I don't have faith in many even great pathology labs that think they can do this. You will have 20% of the samples fail to get even readable cilia at the best centers in the world, okay? And you have to do this when the kid is not viral. You have to do this when the kid hasn't just had surgery. Any insults to that nasal pharynx when the kid's got an NG tube in and being suctioned by the ICU nurse all the time will mess up your EM. And we know that even with proven PCD through genetics, 30% will have completely normal EM. So what about genetics? There's been an explosion. We're over 60 genes since I started doing this in 2007. And to put it in kind of perspective, look at all these genes lined up. Look at all the exons you have to cover. Some are massive. And then you see that nice little pink gene for CFTR. That's the CF gene that I grew up with. And it took us about 40 years to understand it. And it's about a third the size of some of our common PCD genes. Think of all the variants of uncertain significance you get. When you order these, you need a really experienced geneticist to understand it. It's not just autosomal recessive. We have X-linked causes. We have autosomal dominant causes. It's a real mess, honestly. And when someone says to me, okay, what is the pickup of PCD genetic testing? Well, it depends where you are. If you've got predominantly white Northern Europeans, then it'll pick up about 82% because those were the initial populations we studied and learned about this. But if you are in South Asia, it's a completely different gene that's driving almost 40% of this, and that's different from the Middle East, and that's different from Japan, and we have no idea what South America and Africa have. And if you look in the north of Canada at our Inuit population, 100% of them have it due to founder effects in DNAH11. So if the gene that's affecting your population is not on the panel, you're not going to pick it up. And this is why people are moving more towards exome sequencing. But actually, you have a much better pickup chance in patients with heterotaxy than you do in a patient without heterotaxy. And the reason is all of the genes in blue that we've recently been discovered to cause PCD, they do not result in laterality defects because they don't affect they don't affect the dining arms. They affect the central apparatus of the radial spokes, and so the embryonic nodal cilia don't need those things to work, and they move normal. And the other thing is many early discoveries of PCD genes were done in people with laterality defects. So we have done a pretty good phenotyping and genotyping job in these people, but it's not perfect because often you won't get 2 hits in the same gene, and that's what you need. 2 pathogenic or likely pathogenic variants within the exact same PCD causing gene, and then that can explain your PCD and your heterotaxy. And they've got to make sure they both come from each parent, 1 from each parent. They've got to be in trans if you have parents you can test. There's still no digenic causes because often you will get back panel results with 5 different hits and 5 different genes, but they're all heterozygous, and you can't diagnose a kid with PCD based on that. Most of the genetic panels that people are using cover 40 to 50 known genes. If you order a heterotaxy panel, the good news is most of those dining arm genes will be included in there, at least the ones known to cause laterality defects, but not all of them. Whole exome sequencing is more accurate. It'll pick up more, especially with large deletions, duplications. And whole genome sequencing, we now know, will add about a 6% increase in diagnostics from the kids where you have single hits. If you then test the whole genome, they'll have intronic variants that increase or give you a positive diagnosis. So what do you do? Well, we've all talked about it. That kid sitting in front of you that you're fairly certain they don't have PCD. Maybe their cough is not every day. Maybe their nasal congestion gets better in the summer, but they've got something. Okay, and so as Dr. Lowe pointed out really, really nicely, if you scrape cells out of these kids' nose, they beat funny very frequently, probably about 1/3 to 1/2 of cases. And if you test nasal NO, you can see kind of intermediate levels. And we saw that where I was a fellow. We have a huge cohort that I never published that showed they have intermediate levels. They're not low like PCD, but they're right, near 100 to 130 nanoliters per minute. And we know that they have worse surgical outcomes, as she showed very nicely. But we also know that not everything correlates. Sometimes there's lower NO, sometimes that correlates with the ciliary dysfunction, sometimes they have increased respiratory symptoms, sometimes they don't, and sometimes we find the same thing in non-heterotaxy heart disease. That kids, about 30% of kids, if you do these tests with non-heterotaxy congenital heart disease, will have this as well. And importantly, we haven't really done a great job of doing nasal NO repeatedly in these kids to see what happens over time, or high-speed video microscopy longitudinally. And so that's what's missing from this. And so we have to ask ourselves, why are these people getting more ciliary dysfunction? Is it due to congenital heart disease in general? Does that impart the risk? Is it abnormal nasal NO levels? Is it a heterotaxy status? Or are we just using imperfect tools to diagnose this? And I think it's probably that. We're not using perfect tools. The tools we're using could be subjective and could be secondarily affected. What we really need is in vivo studies, taking live people and looking at how their cilia work inside of them. Okay, and we need to do that in people with and without heart disease, in people with just laterality defects and not heart disease, in people with just VSDs. We need to do this to see if it's all around heart disease, and we need to do it in healthy controls. Okay, and we need non-subjective, standardized, reproducible tests when patients are in their baseline state of health, and that's key. Anyone that does a test on a kid and you're trying to convince me that they have secondary or some type of ciliary dysfunction, you got to tell me they don't have a virus on PCR at the same time, okay? Because kids are just full of viruses. And so we actually have a test for that. It's called mucociliary clearance testing, and the most common methodology is using a radio-labeled isotope of technetium-99. And you can inhale that into the lungs, and you can watch with a gamma camera scanning people, it's minimal amounts of radiation, over 1 hour, 2 hour, 24 hours, and you can see in the above images here, at 24 hours they've cleared all the tracer out. And then you can see in an abnormal person that tracer's collecting in the large airways and not forming boluses discretely that move up into the trachea and are swallowed in the esophagus. And we actually have international recognized protocols for this from the Cystic Fibrosis Foundation. There's about 6 to 10 centers across the US that do this well. And we have a European standard out of Copenhagen, Denmark that does this well. And we're using this as outcome markers in PCD restorative therapy trials as we speak. So we have the tools to do this. And this is basically what you can do. You can put a patient with PCD or heterotaxy with PCD in front of a gamma camera, and you'll see they have absolutely no mucociliary clearance until you tell them to cough. And then they'll start moving stuff. And you can compare that against children with cystic fibrosis who have some mucociliary clearance, but it's not robust, and normal patients who clear about 30% of their inhaled isotopes by 1 hour. And this has actually been done in PCD patients, where Sharon Dell in Toronto took almost 60 patients with presumed PCD, but she couldn't prove it in all of them. And she used a reference standard of abnormal genes, abnormal EM, or repeatedly low nasal nitric oxide. And if you did a mucociliary clearance test with 2 hours worth of scanning, you could actually confirm that they had abnormal mucociliary clearance in 95% of the cases compared to the gold standard. And it was incredibly sensitive and specific. And it could rule out ciliary dysfunction with 100% sensitivity, basically. With 100, you could rule it. Spin, snout, sensitivity rules out. Yes, you could rule it out with 100%. So that's what we need to do in this population. I'm convinced there's a signal. I'm convinced Dr. Lowe has shown us there's a signal. I'm convinced there's something there. We need to prove it, though, and we need to prove it with good in vivo testing. So I want to thank, these are my PCD folks, mad props to the PCD folks, including Michelle Mannion, who is our version in the PCD world of Nisha Sabin here, and has really driven all of the work we've done in PCD along with our researchers. Thank you guys so much.